Good afternoon. My name is Kimberly Cooper, and I am the Infection Prevention Manager for Ambulatory Care Services at Harris Health System. I am a registered nurse and CPHQ and CIC certified, and have been working in infection prevention for 11 years. I wanted to give some insight on to our abstract safe practices through automated surveillance in an ambulatory surgical center. Surgical site infections are amongst the most common reported healthcare associated infections. One component of a successful outpatient infection prevention program is hospital associated infection surveillance. However, reviewing charts manually and relying on providers to self-report in labor intensive and limited, where we also discovered that in average, the response rate was 30% with no identified post-surgical infections. We know that this surveillance style reduces time spent and other quality-driven projects. During the height of COVID and monkeypox, we needed to optimize time spent reviewing charts and cases. Our goal was to develop an automated surveillance platform for ambulatory surgical procedures, improve patient outcomes with early identification of SSIs, reduce SSI infection rates by implementation of best practices supported by SSI root cause analysis. And we also wanted to create surgical bundles and best practices based off of those findings. The project was launched in 4 phases, beginning in the first quarter of 2021 to implementation and go live in January of 2023. We created a surgical site dashboard and provided user access. We identified key indicators and tested with new triggers within the electronic health record, such as return to the emergency department or positive drainage for surgical site infections. We also modified current triggers to decrease activity with the data, as well as we ensured that the outpatient criteria denominators data was accurate. As we worked through each phase, we continued to retest and refine the data for accuracy. In phase 4, we met to create a process workflow while moving to production of NHSN and non-NHSN denominators for surveillance. Once launched, we immediately began to identify SSIs from the outpatient ambulatory surgical center, which in the past had gone undetected. This project simplified and standardized the surveillance process, which will improve overall patient outcomes because best practices can be implemented when surgical site infections have been identified accurately. The method was an overall success. By abstraction of accurate and reliable patient data from the electronic health record onto a centralized dashboard via automation, where this information was compared to NHSN standardized criteria in the outpatient setting. In conclusion, our team identified that the use of the automated surgical site surveillance identified more infections than previously reported, as well as improved communication between surgeons, administration, quality, and the infection prevention team, which will mitigate the risk of surgical site infections, creating safe practices and improving our overall patient outcomes. Thank you for listening to my presentation on safe practices through automated surveillance in the ambulatory surgical center. If you have any questions, we can be contacted at kimberly.cooper@harrishealth.org. Thank you.
All right. So, hello, my name is Yolanda Wall. I'm a nurse and operations specialist for Linda B. Johnson Hospital at Harris Health in Houston, Texas. The poster that I'm presenting is focused on surgical site infections during my role in infection prevention. A little bit of information about Harris Health System. We are an integrated healthcare system that encompasses health centers, same-day clinics, specialty clinics, and 2 full-service hospitals. This is very important to know. Because of our integration, we are able to provide care to our patients throughout their continuum of care. So once they are integrated into our system, we can see them from various healthcare aspects. So let's begin with the why. As you may know, NHSN published back in 2021 that there was a 3% increase in the SSI standard infection ratio for all NHSN operative procedures. While there has been advances in infection control practices, environmental factors such as ventilation, sterilization procedures, and even surgical technique, SSI still remains a substantial cause of morbidity for this population. At Harris Health, we've seen some small gains with decrease in SSI rate. However, we continue to analyze and develop sustainable solutions for meaningful change. With our electronic health record, we're able to perform active surveillance both from the inpatient and outpatient setting. But as IPs, we recognize that identifying the infection is only telling a portion of the job that we do. Knowing the cause of that infection helps us develop those solutions for prevention. And so, to that end, back in 2021, we began developing what we call our CAT tool, or our electronic case analysis tool, to understand lapses in infection prevention process that may contribute to an SSI. The goal was to develop a user friendly review process to accurately identify SSI root causes, and then, based on those findings, develop quality improvement initiatives to prevent future SSIs from occurring. Our overall SMART goal was to decrease our health system colon SSI seers by 25% before June 2023. The first step with our initiative, which you can see here listed under strategies and implementation, was to develop a structure to analyze each identified infection. The structure must encompass all patient care settings. So we're looking at our specialty clinics for when the patient is optimized for surgery, the actual surgery suite, looking at some of our colon bundles, post-op care inpatients, all the way through their follow-up visits in the surgery clinic. So we started our tool development by investigating best practices via literature reviews. We looked at various industry standards from our neighbors throughout the Texas Medical Center, the Houston Medical Center, and also our internal policies and procedures. From there, we engaged key stakeholders for feedback on our proposed tool. Then, based on their feedback, because we got plenty, we narrowed it down to pertinent information to help drive the identification of root causes. In addition to this, we also developed what we called our abstraction guide. And this was to help assist our IPs in identifying where to locate this information when they were performing chart reviews. For example, how to find in the medical record where smoking cessation education was provided, or something down the lines of when anesthesia may be looking at blood glucose and where they may document that at. Having this defined tool in the guide was pivotal to our success, and it supported inter-rater reliability amongst our team. Once the structure of the tool was complete, we integrated it into our electronic chart review software, and this helps us to look at long-term tracking and trending for any variances that were identified. Once we had our structure in place, we then focused in on our process, which is our review. Okay, let me pause right there. Sorry, I was going too fast. Okay, and I'm going to start from the top. Okay, so next we tackle establishing a process for our interdisciplinary review. Once the SSI was identified by an IP, the case is discussed internally with our IP team and leadership, and if the NHS criteria was met, a communication was sent to our key stakeholders for what we called our weekly HAI review. The review meeting included surgeons, anesthesiologists, nurses, both from the operative and inpatient setting, executive leadership, and of course, infection prevention. The case analysis tool was distributed prior to the meeting to allow stakeholders the ability to review the case prior to and be prepared to speak to their challenges, barriers, or any successes. The weekly review is a standing meeting on everyone's calendar. If we did not have a case review for that week, we simply canceled the meeting. It's important to have that dedicated pre-scheduled time to ensure optimal participation, particularly for our surgeons and our anesthesiologists that were constantly in cases. During the review meeting, our IPs will identify the infection that was. Okay, let me pause right there. Do a 5 second pause. All right. So during the review meeting, the IP will who identified the infection will present the case, and this included where the case met NHSN criteria and variances identified during the chart review. There was open discussion amongst the team to understand any variance, and it tackled everything from environmental concerns to general infection practices. Comorbidities or patient contributing factors were also included. So, through the initiation of this process, we were able to identify improvement initiatives to help bring down our SSI SEER. You can see some of the initiatives that we have highlighted here under evaluation and outcomes. Most notably is having a update to our post-op template. This is very important because it served as a visual reminder for our surgeons to document whether or not pathos was present or a infection was present at the time of surgery. This simple um, yet significant change help improve our documentation because, as we know, even though the SSI has to be reported, if pathos was noticed, then it does not count against us in our SEER. As stated previously, other notable initiatives that we put in place is listed here under evaluation and outcomes. During the first 6 months of our implementation of this process, we was able to identify multiple root causes, as you can see listed in our fishbone. And through this work, smaller task force were developed to implement change. So we pretty much did a divide and conquer technique, looking at each root cause and seeing what improvements we can put towards that. So both the SSI tool as well as the weekly reviews are still practiced today. And as of June 2023, this year, we have seen a 50% decrease in our colon SSIs in comparison to 2022. And we continue to see other successes with NHSN procedures such as hysterectomy. So it's not just limited to one procedure. If I had to narrow our success to three takeaways, I would say developing a standardized tool is key in helping you identify your root causes, ensuring optimal engagement at all levels in your healthcare team, and ensuring that everyone on that team understands the intent of the reviews. And then, probably the most important is being comfortable with acknowledging and accepting failures so you can learn from them. It was a little difficult in the beginning for us to accept those failures, but once they saw how speaking up and saying things that may have went wrong helped improve their overall practice, we start getting more engagement and more participation. That concludes the poster. I want to just say thank you for giving me this opportunity, and hopefully you learned a little something from my presentation. And if you have any questions, please feel free to reach out to me via email. We are happy to share our best practice details even further. Thank you.